All right, Avi, we're ready for you.
Perfect. Hi, everyone. So the case that I'm presenting is essentially with the chief complaint of pressure-like chest pain, described as an elephant sitting on the chest. Um, so very classical in a way, but how I'm going to put across the story is how essentially we found the patient, which is what makes it super unique for me in a lot of ways. So this was a 45-year-old female with past medical history of HIV, alcohol use disorder, and mechanical aortic valve status post and enterococcal fecalis endocarditis a few years ago, who initially came in for concerns of alcohol withdrawal, and she had 12 drinks of gin about 12 hours ago. She reported having headaches, tremors, palpitations, diaphoresis, and tactile hallucinations at presentation, which improved over some time while inpatient while she was on a barbiturate taper. But while inpatient, she complained of a constant pressure like pain out of nowhere, described as an elephant sitting on her chest, which radiated to her jaw. She denies any similar episodes in the past, no shortness of breath, and she was pretty conversive, hemodynamically stable, except her heart rate was 127 at that time. Um, I can just give some pertinent past medical history and surgical history alongside. So she's had multiple episodes of renal colic in the past. She's also had a cholecystectomy in the past and did actually have an SMA mycotic aneurysm repair in 2020, secondary to the same enterococcal fecalis endocarditis as a mycotic aneurysm. Uh, the medications that she's on or is supposed to be on are an ART antiretroviral therapy, dolutegravir and lamivudine, besides warfarin, metoprolol, and aspirin. Social history pertinent for 23 years of 23 pack years smoking and almost 10 to 12 shots of gin every day for the past many years. She also accepts using marijuana. Nothing pertinent on her family history. I
Excellent.
think that's
All right.
it.
Avi, this is a phenomenal start. Thank you for putting together this case. And I think can see the narrative skill set and the poet in you coming across in the way that you tell the story. So it sounds like we have a middle-aged woman with a history of HIV, prior endovascular pathology, both in the aortic and the mesenteric circulation, who was admitted for alcohol withdrawal, but now has developed a chest pain syndrome characterized by chest pressure with radiation to the jaw. And I think whenever we have a chief concern as morbid as chest pain, we always take a systematic approach to this, no matter the individual who has the chest pain. And so we can think about the cardiac, the pulmonary, and the GI system. The cardiac causes, as many of you know, we think about the acute coronary syndromes as well as aortic dissection. And then we can also think about some diseases that may mimic the acute coronary syndromes, which could include something like Takotsubo cardiomyopathy and tamponade. I'll be honest, whenever I see patients in the emergency room, the vast majority of my cognitive energy goes into those first two, ACS and aortic dissection, as the cardiac diseases that can cause chest pain. But I think in this case, there's reasons to bring at least one of those other ones into play, which is Takotsubo cardiomyopathy, at least early on. And the two reasons for that is that we have somebody who is relatively young, so may not necessarily have all of the risk factors that we would think about accumulating over time for developing significant coronary artery disease, who is in a state of what sounds like pretty profound sympathetic excess in the form of their alcohol withdrawal. And we know that one of the sort of unifying drivers of Takotsubo cardiomyopathy could be high sympathetic outflow over a relatively acute or hyperacute period of time. For example, as Avi knows, as a neurologist, we see individuals who sometimes have Takatsubos after a seizure, which is an enormous sympathetic outflow state. We sometimes see Takatsubos after emotional distress as well. And alcohol withdrawal is similarly a state of sympathetic excess. Would we consider Takotsubo before we consider ACS? Certainly not in this case, because the morbidity and the commonality of an acute coronary syndrome make it the most important diagnosis to consider at this point. But given that she has a history of aortic pathology, we could bring the aortic, we would bring the aorta into play as well. And then it's important to note that even though she is only 45 years old, individuals with HIV are at an increased risk of developing coronary artery disease very early on. The inflammatory state of active HIV viremia can accelerate the development of atherosclerotic plaques. And so we can see diseases that we usually associate with aging present much earlier in this population of individuals. So that's sort of how I would be thinking through the cardiac sides of this, but acknowledging that there's also non-cardiac diseases that could be causing chest pain. And I'll turn it over to you, Sharmise, for those pieces or anything else to add.
Well, that was beautiful, Jack. And yeah, as you nailed it, to be honest, first pass is just rule out those no misdiagnoses, ACS, ACS, ACS. I think like pulmonary embolism is like another one that, oftentimes whenever you think is a PE, is never a PE. When you don't think is a PE, is a PE. So that's another good one to remember, especially if the cardiac etiology is lower, becomes lower with further workup. The other thing that I just kind of wanted to zoom out and keep in the back of my mind as we're going through the case is that she came in with alcohol withdrawal. I'm not sure exactly how many days she was inpatient while, and then just chest pain developed, but like delirium tremens, thinking about like excess symptomatic response, like that's something to keep in mind because again, the autonomic instability of that could be life-threatening to a patient. So sometimes despite our best effort of like treating the alcohol withdrawal, people do develop DTs. So that's something I want to be mindful of like going forward. And in terms of like her past medical history, in terms of like, getting a sense of her med adherence as well with her HIV. So getting a better sense of like her CD4 count, I think will be informative. And in terms of like history of like endocarditis, I'm just curious to know how long ago that was. And if there's any complications of that, long-term complications of that we should keep in mind as we're going through the case. And especially with like and mechanical valve, and if she's like consistent taking her warfarin or not, like that's another thing to keep in mind to evaluate for. Curious that she's taking aspirin. I wonder if that's kind of like thinking about why she's taking an aspirin. Does she have like underlying coronary artery disease? Is there another etiology as well? So I'm looking forward to hearing more from you, Avi.
Yes, absolutely. I think those are all very wonderful points to especially help broaden how we're thinking. Because that is one thing I felt as well. Someone came in for an absolutely different reason. We already have our preconceived biases. Oh, this is straightforward alcohol withdrawal. She was put on in the ED on barbiturate taper. So a lot of things going on in there. And like the chest pain was not even on our radar and it was suddenly happening. So threw us off a little, but that's why protocols exist and that's why we did the things that we did. So a few other things that might not be as pertinent, but just to mention to help broaden the differential. So she did have on her review of systems right upper quadrant pain. She did endorse left flank pain as well. She did say she's had multiple episodes of vomiting in the last 2 days. So during this time, she was only inpatient for less than a day when she already started endorsing the chest pain. Moving on to a basic exam, and I'll try to give you a timeline alongside it. Initially, when we examined her, the only thing that was positive were her fine tremors. She did have the left flank tenderness, which she said is very consistent with her prior episodes of renal colic. She did have the right upper quadrant tenderness. She did have an umbilical hernia, which wasn't causing any problems. Um, Besides that, at that time, the only thing on her cardiovascular exam I could find was a mechanical sound, which was pretty much consistent with what I expected, but nothing out of the ordinary, at least to my ear at that time. So once she does endorse this chest pain, we got an EKG at that time, which essentially did reveal only one new Q wave changes, but nothing acute for this instance at that time. To add a few labs that we got at that time, her sodium was 127, her potassium was 3.2, her alk phos was 641, AST was 493, ALT was 129, PT INR was actually 1. Great if you're not wanting someone to have a great INR, but in her case, not so great because she's supposed to have a better INR. LDL was 154, white count within normal limits at 8.9, and HB was 10.3. We also did a CD4 right away, which was 174, so less than 200 there. And this was when we got all the labs. And once she did have the chest pain, we got the tropes, which came out to be 2131 at the time. So I will stop it there for the second aliquot, and then we can go ahead from there. Yeah.
Oh, right. And that's a high sensitivity trope, Avi. That's to be.
That's correct. Yeah.
Whoa.
Sharmin, can you help me convert what that is in the for us muggles who don't use the high sensitivity trope? Is that 2.1?
The conversion. So like high sensitivity trope, anything above like 20, I would say like is kind of positive. So yeah, does anybody know the conversion actually?
I can look it up too.
I think it's pretty close to what Jackie said. I think
it's 2.1. Yep.
Yeah, it's 2.1. All right, thank you, team. Yeah.
PPRS and old school troponins. That's my life.
It's amazing how easy you lose it after you just like convert your mind to it. All right. Okay. So we're and obviously one last question. What was the blood pressure was okay?
Yes, the blood pressure at all times was within normal limits, but I can give you a number. It was about 170 by 90. Oh, sorry, not 170 by 90, 150 by 90.
Okay, great. So one of the reasons, again, I just want to make sure, like she's tachycardic, like you want to make sure, she's doesn't have any like shock pathology. So like getting a lactate, I think is also a good idea in this case. In terms of like what to do with that exam, one thing that, again, as you were obviously revealing data, that one thing I was wondering is like, thinking about aortic dissection. And sometimes like as aortic dissection expands, people's chest pain moves towards the abdominal part. So when people complain of like moving pain, that makes me a little bit more worried about aortic dissection. And then in terms of like the lab findings, the one thing that, again, like if you think about like what is your no misdiagnosis here, I still think like acute coronary syndrome is the one that we have to think about. When you think about that, you think about like what is the history that a patient is telling you, and she has sudden onset chest pain, abdominal pain in someone with underlying immunodeficiency. And, as a woman, a lot of the time, women can present with atypical findings. ECG is not that revealing. Again, if those Q waves are new, I would, again, like you kind of want to trend your ECGs, like you trend your lab. So making sure you're repeating or continuously running it if it continues to have chest pain. And then with that elevated trope, then you really, really want to think if this is a acute coronary senescence of an STEMI. So would I treat her for that? Yes, and I would call cardiology. I would heparinize her. Again, like she has a mechanical valve and her warfarin is not therapeutic. So I think like giving her heparin in this a moment, I'm thinking about loading her with aspirin, statin, and then call cardiology. A lot of the time, I wait on the second antiplatelet agent until I get the okay from the cardiologist. So this is someone that probably should cardiology think about whether they want to take her to the cath lab. At the same time, I think like with the abdominal pain and everything, thinking about aortic dissection and sometimes like putting out my personal echocardiogram skills are not good. But so if a cardiology fellow can put it on, and sometimes like if you see aortic dissection, you can see the flap on the echo, or thinking about this is someone that we should investigate that before the cath lab too. And you can get a sense of a ejection fraction too. But I do worry about ACS in this patient. However, I don't want to miss an aortic dissection. The other thing to think about is, a pulmonary embolism, but it sounds like she's statting well, not any pulmonary finding. However, I've recently took care of a patient that wasn't tachycardic, wasn't tachypneic, wasn't hypoxemic, just an elevated tropontin had significant PEs. So I'm suffering from a recency bias. So I'll stop there, and then I'll let Jack layer on the other lab findings.
I mean, that was absolutely phenomenal. I think just to hold or to bring in some of the other labs, as you mentioned, I think there's the thing that's most striking, I think, is the liver enzyme abnormalities and how do we tie that in? And I think there's a couple different ways that we can tie it in. I think one way through the leading hypothesis of acute coronary syndrome is, we see that there's actually new Q waves on the ECG with Q waves being a later presentation of a recent infarction as opposed to signs of acute myocardial ischemia. And so perhaps what we're seeing is pain related to sort of the conclusion of a recent infarct that may have been masked or obscured in the setting of her acute alcohol withdrawal, right? The ability to explain symptoms, attend to symptoms, or even experience symptoms can be blunted in the setting of alcohol withdrawal and the treatments that we give for it, which can reduce people's levels of consciousness. So if indeed we are dealing with an infarction that has reached its conclusion, there could be coexisting reductions in ejection fraction, which could lead to the development of hepatic congestion and hepatic stretch, which we can see oftentimes in individuals who have heart failure, right? Congestive hepatopathy can lead to a low-level transam anemia, and there can be some passive congestion of the liver, and that can lead to some stretching of the hepatic capsule and cause right upper quadrant pain. So one hypothesis is we bring in the liver enzymes by saying, okay, there's chest pain and hepatic congestion. The other hypothesis, which is probably less common, but still possible in the setting of an aortic dissection, is to say, oh, potentially there's a disruption of the blood supply to the liver, and we're seeing the beginnings of a rise of liver enzymes because there is a dissection in the aorta that is now impacting the arterial supply to the liver. The reason I say that that's less common is because the liver has such robust and redundant blood supply. So even if the hepatic artery takes a bit of a hit, we still have the portal vein that's supplying some blood to that precious organ. And so that's a harder line to draw, but I think still one that is possible. And then the third one that we can say is, oh, potentially the hepatobiliary system is the center of gravity of the case, and the chest pain that she's experiencing is actually related to diaphragmatic irritation. So I think one way to twist this is to say that there is thoracic pathology that's bringing the hepatobiliary system along for the ride. There is great vessel pathology that's hitting both the thoracic and the abdominal cavities, or there's abdominal pathology that's bringing the thoracic system along for the ride via the structure that connects the two, which is the diaphragm. I think from a base rate perspective, we have to take the most morbid one seriously first, which, as you said, Sharmin, is the possibility of aortic pathology. I love so much that you brought that in because it may influence how comfortable we feel heparinizing her if there is a dissection flap there. So that's a critical question to answer if it's occupying a substantial portion of our differential before starting ACS therapy. And as you said, it may influence how they approach the catheterization decision here, acknowledging that PCI may not even be, she may not be a candidate for it if there was an epicardial coronary artery occlusion, if that infarct has completed with the Q wave. So lots of really rich management reasoning here, reasons that I'm glad I'm a generalist and get to learn from the people who have to make the hard decisions in this case. But I think it's really important for us as generalists to be able to know what questions need to be asked and answered, and thus who to bring to the table. And I'm with you 100%, Sharmin. I think the dissection question has to be answered, and then also the ACS question needs to be answered before entertaining other things.
Yeah, I totally agree. Like this is someone that I would think about imaging before, either like starting the ACS or before like in conversation with cardiology before like anything else happens, especially if someone's like hemodynamically stable. So yeah, I loved how you tied in the liver and like there's like three different pathways, and it was just beautiful to hear how you walk through us.
Perfect. I think you've both brought great points. And a reason that I wanted to present it like this with all these multiple lab abnormalities was that's how it struck us. Like there's so many different potential problems happening. So you want to keep your differential broadened, try to connect them, but at the same time, try to prioritize things based on what's urgent and what's emergent. So like you guys mentioned, we did pretty much of those things in relatively a right order. We got some imaging. We were concerned about PE as well as aortic dissection. So we got a CTPE, which essentially did not show any concerns for any significant either PE or any dissections. The other thing we got was a serial trope and serial EKGs as soon as that was done. So the EKG still trended to show no acute changes, no ST elevations. But the next trope did come out to be 4,000, and the next one after that came out to be 6,000. This was in the same day. So we reached out to cardiology. They instantaneously wanted us to get an echo done. I would put in what we saw on the echo there. So the ejection fraction on echo was 45 to 50%. We did see some apical hypokinesis on the echo, but importantly, which is something that everyone's been talking about, so rightfully, we did see a concern for a mass/thrombus on the mechanical valve. So that was that. Right then thereafter, we proceeded overnight with a left heart catheterization. As per the LHC report overnight, they saw that there was concerns for uh, an occlusion in the LAD as well as the two diagonals. And I can talk about those things later, but what we ended up doing over there was obviously have her on heparin right away. The chronic problem at the same time was ultimately getting her on warfarin. So the heparin in the moment was acting as a bridge at the same time. So like two birds with one stone kind of a picture. At the same time, they did not see any concerns for any coronary artery disease. So that did not explain the occlusion of the arteries in the heart. So they did not recommend getting any aspirin on board. Actually, they discontinued it for that time, but they continued the heparin. So I think that was a very neat point to me why very specific medications were used for very specific purposes. And Also, no PCI was attempted at that time for multiple reasons. One, it was a distal occlusion. The other point was that it had been 24 hours since the onset, and the tropes had started downtrending spontaneously by then. They were coming down to 4,000s. So as of those things, this was one of my penultimate aliquots.
This is incredibly rich, Avi. I think this sets us up for, I think, a really interesting discussion when we think about the causes of acute coronary syndrome. We oftentimes say that acute coronary syndrome equals atherosclerotic plaque rupture. And that's because that is the cause of acute coronary syndrome in the overwhelming majority of cases. But there are other ways in which epicardial coronary arteries can get occluded. And we say epicardial coronary arteries because there's many small coronary arteries within the heart that are sort of part of the microvasculature that supplies the left ventricles. But the ones that get obstructed that lead to major ventricular infarcts tend to be what we call the epicardial ones, or the named coronary arteries, right? The right coronary, the left main, the LAD, the left circ, and their branches like the diagonals coming off the LAD and the obtuse marginals coming off the left circumflex. And so they can get occluded, one, through atherosclerotic plaque rupture. That is the most common, but it is not the only way. Other ways that we can see disruption in blood flow through the coronary arteries include coronary artery dissections, which can be spontaneous or iatrogenic in the setting of coronary catheterization. But then very rarely, we can also actually see embolic coronary artery occlusions. And this comes up in certain scenarios in the setting of aortic valve endocarditis, where there is a vegetation on the valve, and then that vegetation, a piece of it embolizes into the coronary artery circulation and causes basically septic emboli to the coronary arteries and leads to an infarct that way. There is a phenomenal case report from a former CP Solvers team member, Smitha Ganeshan, that I encourage everybody to read, that describes this phenomenon of septic emboli into the coronary arteries. Based off of the echo that we saw, we see that there is indeed thrombus on this mechanical mitral valve. And this is in somebody who has been under anticoagulated with an INR that's subtherapeutic for a mechanical valve. The goal being 2 to 3, but we're in 1.5 here. So based on the cath results, an absence of CAD, the presence of a thrombus sitting on a mechanical valve that is probably just sitting right up against the sort of portal of entry into the coronary circulation, makes you wonder if indeed, rather than being plaque rupture or arterial dissection, this was actually an embolic embolic event into the coronary arteries, leading to acute coronary syndrome. Yeah, so I'll pause there. I think the management of this is one that I have never done before, but I saw Sharmin nodding a lot when you were describing some of the management decisions. So I'm excited to hear her take on the management of this finding. But I think from a diagnostic perspective, it seems most likely that this is acute coronary syndrome actually from mechanical aortic valve emboli.
Yeah, no, I was nodding along because I just love listening to you discuss, and that was beautifully done. Yeah, I think in this case, as you mentioned, like the two that I was worried about was the two that you mentioned, right? Like we know she's undercoagulated for her mechanical valve, so that's one source, and then she has this history of like endocarditis as well. So while if you ask me like what probably is the most common is like that thrombus is just blood that is sitting there, and that is what we need to. But I just again, someone who's like immunocompromised, just thinking about like, is there any other nidus of infection or the endocarditis that was potentially undertreated? Again, I don't know what the time course of that is, and I'm thinking about like why she developed the endocarditis in the first place, and if it was like injection drug use related, if she still continues to have this behavior, is she at a risk of another bout of endocarditis? If it was, in a setting of a GI pathology or anything else like that. So I think just as abundance of cautious, I would investigate that a little bit more while like making sure she is anticoagulated. And I think the most important thing going forward for her is to help her support in being able to take her medications on regular basis. As we all mentioned, she's 45 years old. So whatever we can do to support her in regards to just being able to take those medications, I think is going to be the thing that makes the biggest difference.
That's been almost the same thought process that our cards folks have had, that it was possibly a microemboli causing the obstruction of the LAD and stuff. And that's what we ended up doing. And I agree that ultimately it stemmed out from something that could have been prevented just by taking your medication much more regularly. And it led to consequences like her having a STEMI an MI that she never had. And at the same time, we understood by the time, because she was one of those patients who was motivated enough to not have this again. So we found that a good opportunity to make her compliant with her medications, which I felt super comfortable with. But another thought process that I had by that time was that she's on warfarin, which does have a lot of drug interactions. So this ended up being a great case for multiple thought processes in that direction. She was one of the few patients who was on barbiturate taper for her alcohol withdrawals. So that was one question I asked myself. But that was something that was going to be off in a couple of days. So that wouldn't have actually affected as much of her warfarin goals. The other thing that we also did think about, because her CD4s were less than 200, she was going to get started on Bactrim, which we kind of already did because at that time she hadn't had that chest pain. So the other question I had was, now that Bactrim is going to affect the levels of the warfarin. But the good thing was, again, because now she was going to be on Bactrim and warfarin at the same time, the monitoring of the INR was essentially going to be the same process. So, because she's going to be monitored for INR while being on both of them together. But I think that these 2 points were still very reasonable to have been thought about. And sometimes we just end up thinking that, oh, this person's not taking warfarin or not taking their medication. But in fact, someone's been on multiple medications and they can have interactions. So besides the very principal learning point of acute myocardial infarctions caused not due to atherosclerotic disease, I thought that there were many little caveats to this case that I self-taught myself, and I wanted to like share it with as many people. Uh, but I think that's the end of the aliquots from my end.
Avi, thank you so much. This was such a fantastic case, and I loved your reflection. And no, thank you. And thank you so much for bringing that up, because you're right. Like, we made the assumption that she's probably not taking her warfarin and then holding space. That no, we could be wrong about that. And, medication interactions is like such a wonderful thought to have, and to, especially in someone, as you mentioned, on warfarin, to like keep that front and center and just have that kind of respectful curiosity, and look into it more. That was fantastic. This is an awesome case. Learned a lot. So thank you for being here. Jack, any other thoughts from you?
No, I echo the same, Avi. Phenomenal case. You sequenced it brilliantly. I think like the tension, it really felt like we were there navigating the dilemma that you all were facing in the moment. And I think that makes for the best opportunity for what I think we all come to this in hopes of doing, which is to transfer what we do here into our day-to-day practice. And by really simulating the challenges and the uncertainty and all of the mess that's really oftentimes present in cases like this, it gave us all the substrate to prepare to make that jump from the structured case setting into the real authentic clinical practice environment. So thank you for bringing this and setting it up the way that you did. I think it really elevated the learning here.
Thank you so much, both of you and everyone on the team. It's been a pleasure to have brought this to so many, and having this platform for so many of us to just bring to light things that we learn and everyone can learn from them as well. And thank you for creating that little bit of nervousness within me that I'm going to present something after so long. But I think that just keeps pushing us to keep growing and keep learning and never feeling that we're not a student. So thank you.
Excellent. All right. Thank you again, Avi. Harry, why don't you go ahead and bring us home with the teaching points here?
Sounds good. Great kids. So as always, our checkpoint approach in terms of our can't misses, we like the 4-2-2 here. Cardiac being one with the 4, ACS, aortic dissection, tamponade, stress cardiomyopathies. In terms of pulm, PE, pneumothorax, or can't misses, and GI causes of esophageal rupture and impaction. In terms of ACS, just remember that females more often than males tend to present what we call our atypical symptoms, which can include nausea, vomiting, and I didn't include this here, but it tends to happen more in folks with diabetes, which is not this case. Tying together liver function enzymes and ACS, just sometimes acute ACS can lead to heart failure, which can cause hepatic congestion. Our initial ACS management for those who match and are going to be interns here next year, we like to do aspirin, heparin, and statin up front. Some folks like to wait for their second antiplatelet agent until after the cath. Think about stress cardiomyopathies or toxin cardiomyopathy when patients are young with ACS-like syndromes, but don't have traditional cardiac risk factors. Folks who have HIV are also inflamed and increased risk of plaque formation. Avi had a great clinical reasoning pearl. Don't anchor on the patient's initial presenting syndrome. If a new symptom develops during the hospital course, take it seriously and don't anchor. Dissection, as it can progress, the pain can move around, and then causes of epicardial artery occlusion are traditional plaque rupture, or dissection, embolic phenomena, including septic, or in this case, mechanical valve. And then just remember, Avi brought up at the end that warfarin has a lot of drug interactions that can affect the dosing in INR. And that's all I got.
Great. That was awesome. Thank you so much for doing the teaching point. Shout out to Preet for doing scribing, and Avi, what a pleasure. Thanks again. And thank you all for joining us. We'll see you tomorrow. Have a good one. Bye.
Thank you, everyone.